Thank you for doing that. It is my honor to introduce Dr. Chris Lathan today to deliver our seminar. Dr. Lathan is an associate professor at Harvard Medical School and has what I think is one of the coolest titles ever, Clinical Access and Equity Director. I mean, that's pretty cool thing at Dana-Farber, but he also holds several other important positions at Dana-Farber. He received his medical degree from Tufts and trained at Boston Medical Center as well as at Dana-Farber. He is a thoracic medical oncologist and continues to practice in addition to his research and community outreach and engagement activities. One of the things that I think I want you to know about Dr. Lathan is that there are very few people that have invested as much time, energy, effort, and thought into trying to bake in equity and representation into our healthcare system. He thinks deeply about these topics and works arduously toward achieving them both at his institution, but also helping others at other institutions achieve those same values and really putting their mission to work. I had the benefit of first getting to know Dr. Lathan because he was serving on a board of a foundation that was funding my research. And so we attended several meetings together, and I quickly realized that I wanted to spend more time where Dr. Lathan was spending time because of the opportunity to learn from him and gain from his perspectives. And he doesn't really know this, but he's been an external mentor to me in a lot of the equity work that I've tried to do. And my own career has been informed by some of the fundamental ideas that he has put in the literature and shared with me personally. Dr. Lathan is someone who works on equity at multiple levels. He's served multiple boards of unhoused individuals in the Boston community, on working in racial ethnic communities with sexual and gender minority communities. Is someone who really walks the walk and talks the talk and takes the action at pushing institutions forward in achieving health equity, both in terms of access and outcomes. He is someone who has degrees and obviously in medicine, but also public health and cellular and molecular oncology, and just thrilled to have him present his ideas to us today. So Dr. Lathan, and I'd also like to recognize you from the University of Colorado Cancer Center with this recognition of your presentation today as a recipient of our Cancer Warrior Award and someone who we're really excited for you to share your ideas with. So you take that.
Thank you, Jamie. Thank you very much. So can you guys hear me? I'm supposed to be mic'd and I might wander a little bit if that's okay. I don't like to stay in one place. And no reverb, right? Are we good? Should I turn this off here? Okay, we're good. All right. Good. So first of all, thank you for that introduction. Before I started, Jamie's like, is there anything I could say that could embarrass you? I said, no, I take that back. The appreciation is mutual. And what I want to do today, if it's okay for everybody, we got an intimate group here. I'm going to try to make sure, I'm going to go through the slides, but I want to have about 15 minutes at the end for conversation, right? So if there's stuff that you have questions on in the middle, write them down. Because I find when we start having engaging in the middle, we'll have conversation, then I'll be skipping over slides at the end. But I promise if there's, we should have enough time to get to some of the questions if that's okay. So disclosures, right? And then learning objectives, right? Yeah. Okay, so what I want to do, the way we're going to structure this a little bit is do a little introduction about who I am, talk a little bit about health inequities, but this is not going to be a lecture where I'm going to categorically go through health inequities. That was the first part of my career, actually convincing people that they existed, and we don't have to do that. We understand where we are now. Then I want to spend some time on interventions, and I would say that we're going to talk about interventions that we're doing, but these aren't the only interventions out there. I just want to give an example of some of the things that you can do and the way we could think about this, where we can incorporate all the different aspects of what people are doing in the Cancer Center. And I'm going to spend a little time talking about transdisciplinary approaches to research, because I think that's the only way we're really going to develop the tools that we need going forward. And I'll end with some unique opportunities for action. So this is really kind of briefly to tell you a little bit. I grew up in Springfield, Massachusetts, which is home of the Basketball Hall of Fame. But other than that, it also happens to be, it was a manufacturing town in the 70s. Large companies and factories were there. And both my parents were from the South, which is very common for a lot of African Americans. My dad was from a small town in Carrollton, Alabama. I think it's about 1,000 people there. Dropped out of school in the 6th grade. He was functionally illiterate, and he worked in the factory, drove a fork truck, and he also did multiple other jobs, contracting, works on cars. I spent a lot of my time pumping brakes in the car, doing a lot of stuff that working with my dad. He passed in his 50s from congestive heart failure. And the only reason we knew he was sick is because he didn't go to work, because he worked all the time. My mother grew up in South Carolina, just outside of Conway, South Carolina. And she worked as what we used to call a nurse's aide for many, many years in nursing homes. And we lost her too pretty early at the age of 61 to early onset Alzheimer's. And I tell you this to say that the experience that I had growing up in like working communities and working poor communities is, everybody I saw, whatever race they were having the same kind of struggle. And I didn't realize until later in my career, this would really inform the basis of how I wanted to approach things. And this picture up here that we show is it's a slave ledger from the middle 1800s, which just on both of my sides, I'm a descendant of slaves in the US. This is on my father's side. It's Mr. White right there, Joseph White right there, and then many of the relatives listed on the plantation. The Warmth of Other Suns is a great book. If you haven't had a chance to read it, it talks about the great migration of African Americans from the South to the Northeast, the West Coast, and the Midwest to work. It's really great. It's really well done. And then the book that I would say changed my life is when I was an undergraduate at UMass Amherst, and sitting in this large auditorium. I was a biochemistry major, so this was an elective in economics. And the professor came in and started talking about whether or not race was a social construct or not. And I was literally like 18 years old. I'd never really thought about this. And I didn't figure out how this came up in an econ class. But he also introduced me to William Julius Wilson and his work. And that book, The Truly Disadvantaged, which I probably read, I don't know, back in the 90s, really was something that stuck with me. It was a book about policy and working poor in the cities and what really got us to where we are. And I never really thought that this would be something that I would be doing with my career. I was not thinking about going into medicine. I didn't really think about anything other than just getting a job. I was telling somebody my job was, I was a biochemistry major. I spent a little time thinking I was going to be a PhD scientist. Let's be honest, that was not good for me. They knew that. We recognized that early. And then I worked for a few years in a lab, and that's where I met physician scientists. And that's when I thought about going into medicine. So it was, at the time they called me an older student, although I was only 25. Now that's most of the people who are going to medical school have taken some time off. And then when I trained at Boston Medical Center, my thought then, and it was Safety Net Hospital, was thinking about how to dedicate my life to taking care of, folks who needed me the most. And I liked oncology, and I ended up at the Dana-Farber, which is an incredible place. But one of the things I recognized was I was not taking care of the same patients. And that's really what got me started on thinking about a career of how do I find where the patients are? How do we make sure we get the appropriate therapy for patients to match their to match their disease process, and to look at the inequities that were evident there. Just a little primer on our discussion of race, and just to remind people, race is a social construct. There's no biologic definition of race. Race is a shortcut for ancestry. Ancestry is what we really want, right? Where are your people from? Ancestry gets us to genetics, right? So germline genetics in particular. And then genetics really are where we're thinking about our risks for cancer and metabolics, and thinking about that along with our environment and diet. So I say that because I know we know that, but sometimes we forget it when we're thinking about this. And I just want to remind us that. And the other thing I would say on this one is to remember that if we're going to talk about inequities in the US, we can't really talk about it without discussing the impact of the structural problems, right? So it's naive to think about it outside of that. And many people in the beginning would talk about biological differences in cancer. It's so much easier to think about that than to think about the really complex interaction between where you live, where you grew up, the policies that really bring you where you are, access. All those things are a complex mixture. And it's easier to say, well, these folks have a different metabolic process. It's much harder to prove. So, and again, this is a slide that everybody should be, we don't have to spend a lot of time on. We know that cancer is the second leading cause of death in the US. We know that financial distress is a major issue here. And I differentiate from financial toxicity. Financial toxicity is the study of what happens when I say cancer makes you poor. Right? You get diagnosed with cancer, you can't work anymore, and you lose income. But financial distress is what happens when you're poor and you get cancer. So you have financial distress, and how does that impact your outcomes? And we know that it impacts your outcomes, although the majority of the literature talks about how cancer makes you poor. We don't talk a lot about what happens to poor people when they get cancer. Again, that's race agnostic, negative impact on the quality of life, psychological well-being, and symptoms at presentation. And then some things that, again, people are probably pretty familiar with. I mean, specifically talking about African Americans, but you could talk about different groups in general. We know African Americans, generally, the way I look at it, you take a treatment, African Americans are less likely to get it. So diagnosed at later stages, less likely to get the appropriate treatment for their cancer, stage appropriate or not. And when they do get stage appropriate care, actually, sometimes then folks are actually, the outcomes are very similar, which speaks to this being much more of an access issue than anything else. And as our drugs get better, actually, and I'm a lung cancer doctor, so I have a long period of time where we didn't have great drugs. We've got better drugs. And as the drugs get better, the difference between how people do when you get these drugs and if you don't get the right drugs, it's going to make a big difference. And so my concern too is this to transition, this diffusion of technology into communities is really important. And how in the cancer centers, the NCI cancer centers, that is their job. Their job is to translate these incredible breakthroughs and make sure that communities get them. And it's not happening the way we want to. And the last paragraph there is just a little bit on how pop sci folks, how we think about this. So you might see graphs that show you that African-American men have the worst mortality rates, followed by white men, followed by Black women, et cetera. And then there might be something that says East Asian populations or folks who are identified as Latinx or Hispanic have lower mortality rates. But when you look into that and you start being more granular, it really matters what's your nativity, how long have you been in the US, where you're immigrating from, what's the individual risk, right? So sometimes when we are to paint a broad brush with our demographics, we can miss areas of disparities. So just something to think about as we move forward. And this is just graphic information. So the good news for those of us in cancer, right, is that mortality rates have gotten better, right? So over time, they've gotten better. And the gap between Black and white folks in particular has improved. Still remains, but it's better than it used to be. That's a good thing. One of the things I think it's important for us to remember this, right? So we know that for all historically marginalized communities, they receive a lower quality of care, even when income and access are accounted for. Now, that's not to say that income and access aren't important to deal with, but one of the things I think we think about is if I can just fix this one thing, I'm gonna focus on access. If I can just make everything an equal access system, poof, all of these disparities will go away. A whole bunch of literature that says it gets better, but it doesn't go away. And these disparities are all through the healthcare system. The other thing that's interesting to me is, to improve this, we need durable, multilateral interventions. Many of us, because of the way that we think about our research, I'm going to fix this one thing. I'm going to focus on physician-patient interaction. That physician-patient dyad, that's the key. It's part of it. I'm going to work on policy angles to make sure that we have expanded ACA for patients. That's helpful. But it's all of those things at once, over time, in an iterative fashion. And I think, again, this is much harder than people think it is. Doesn't mean it's impossible. We've made some improvements, but we have to think about it like we think about all the other complex work that we do. The other piece over here, if we had more time, was going to talk a little bit about that people power issue. So when you look at look at physicians, we'll take African Americans for a minute. If you're talking, depending on which study you're looking at, 12, 13, 14% of the population in the US, 4% of the doctors in the US. That graph, if you can't see it, is listing Boston hospitals and looking at the percentage of Black physicians that they have there. And so my hospital was listed at 2.2, I think, 2.2%. Boston Medical Center, which is a safety net hospital I trained at, I think we got up to 5. Did it get 4%? Not good is the point. Now, I will tell you, my institution will say, but Chris, that data is 3 years old, and we might actually be up to 2.5% now or 3%. We've made some improvements. I don't mean to make fun of them, but that is true. But we obviously have a long way to go. And to give you an idea about this, right, if you look at this is just a New England Journal paper that came out last year, talks a little bit about inequities. And I'm just going to use this pointer here for this. So what we're looking at over here, right, is the percentage of enrollees in medical school, and you're looking at men and women, and some good news, right? We're getting more women that are in medical school, and the arc looks like they're coming up, and there'll be more women than men in medical school, which is great. And then if you go over here and you break down men and women by racial groups, what you're looking at over here is for white men, the percentage, which used to be 60%, is coming down, while the percentage for other groups is coming up. However, and what I want you to take a look at is Black folks. So for Black men, that since the 1970s almost is exactly the percentage. So it hasn't changed at all. Black women have come up a little bit, had a dip and it went down, and other groups are doing a little bit better, but this is where we've been. So we haven't budged that in 50 years. That's a little disturbing. And then if you want to get really into this and think about descendants of slaves in the US, that number is much less. So anybody who's been on the admissions committee knows what I'm talking about. So, we want everybody from the diaspora, that's great. But if you're looking at people who were descendants of slaves in the US and that percentage are in medical school, it's even much less, much less. So, okay, that's our backdrop. I want to talk a little bit about cancer care and what makes it so tricky. And again, I don't have to tell you guys this, but we're going to go through it quickly. By the way, any slide you see here that's really pretty, I didn't do it. I have a great team. And Emma Green is a magician, and she takes my really messy slides and makes them into something better. Anything that you see that's off kilter, that's my slide. So this is one of the things that I really love this slide because it talks about how complex cancer treatment is. It's really, really hard. It's really hard. And I'm going to go into this in a minute. Like if you look at it, this is something that we published way back 2013, where it's our hypothesis about cancer diagnosis being an iterative process here. And you don't have to go through it in detail, but the idea is let's talk about people who have a PCP for a minute. So let's say you're primary care, and there's a couple of different scenarios that you can start with presenting with your symptoms. You could be asymptomatic and undergo screening. You could have a non-urgent related symptom. I'm a lung cancer guy, so to me that's a cough. Just a cough. And then scenario 3 is urgent symptom that you have to go to the ED for. Again, putting in the lung cancer realm, I would say that bloody cough, like frank bloody cough, that's going to get you to the emergency room. Every place you see a dotted line is places where people could be lost to follow up. So give you an example, you have to take time off to go to work, you go see your doc, doc says, okay, we got this, we got to bring you back in a week to see somebody else. Well, you have to take off another day from work, right? And then you have to come back, oh wait, we got to schedule that film, so now you have to take out more time. You start to lose people. And then that's not even adding in anxiety, fear, babysitter, all the other thing that comes in there. And is it any surprise that it is difficult to do this for working poor populations, right? It's hard. And again, that's race agnostic. There's a universality to this. It's disproportionately impacting Black and brown communities and rural communities. But this is what I call what happens to folks who are in this arena. And let's say that you did go to the emergency room. Let's say for some reason, either you don't have a PCP and that's how you deal with it. You come in, and if you do have some symptoms that warrant inpatient care, because if you don't, they'll quickly triage you and say, get out and then go see your PCP, right? Then you get lost to follow up again. But let's say you do have symptoms. Oh my gosh, you have bloody cough, let's do a scan. Guess what? Yes, you have the straight line, we don't lose you, but you probably have advanced cancer, right? And so we diagnosed you actually probably too late. So this is the reality for many people. And I think, kind of summarizing this, right, as a medical oncologist as opposed to a surgeon, this is a very complex issue. We're the end users as medical oncologists of this complex web of health experiences. Primary care docs, your screening, you might get to us during the diagnosis phase, but as a medical oncologist in an academic center, you're probably diagnosed before you come to see me. And somebody's already made your diagnosis, and then I help you with treatment, palliative care, end of life. So given that, the other problem is the people who have the most disease burden, they have the most restricted plans and least access. So the very people who have the most cancer also have the least access, which doesn't seem quite right? It seems like we should be able to do something about that. And none of this is controversial, right? I'm just telling you what you already know. And then when you look at the cancer centers, like the goal of the NCI cancer centers, all the cancer centers have this problem no matter where they are. The look and feel of the cancer center doesn't necessarily fit the most marginalized communities that are in the catchment area. And, if you think about the clinical navigation programs, there's a lack of consistent clinical navigation programs in most of our cancer centers. Not to say they don't have navigation programs, but is it consistent? Is it integrated into the process? The other thing is, what's the clinical presence in the community? So there's a lot of work that community engagement does. There's a lot of work that people are doing in education. But, you know, what's happening on the clinical side and clinical access, and how are patients being able to be connected to the clinical operations of the cancer center? That's something that's not well developed in almost any cancer center. So summarizing, right, this all matters. Access matters, how we get there. And we need to have high quality cancer care for the underserved. And I think about that very broadly, right? Yes, we're talking about BIPOC populations, elderly, rural, low SES, limited English proficiency, all of those areas. And I think actually you don't have to choose. I think if you actually take care of the folks who are the most vulnerable, you will still be able to retain your high-end patients as well. So this, to me, is not some sort of Faustian bargain. I want to take a moment to think a little bit about our cancer care equity program. People have asked us about it, how it started. I can tell you about this in the Q&A if you like, but the idea is it was around 2010, and I got an opportunity. Somebody asked me a question about if I could build an intervention, what would it look like? And I said, I'd like to build an intervention working with our federally qualified health centers around a diagnostic program that's co-located, that's located in the center, built around a nurse navigator. And we were fortunate enough to get philanthropic funding to start this program back in 2011, and we initiated the program in 2012. And so the vision of our cancer care equity program really spending, well, that was a ghost cough. Spending a lot of on number one, clinical access, facilitating clinical access. That's really where we spend a lot, and that's where the majority of my description will be. We also work very closely with our community benefits department to really make sure we have synergy with the partners that they've been working with. And also, of course, trying to unite the cancer care equity research. So what does this clinical outreach initiative look like? So we have these outreach clinics, and in the beginning, there were medical oncologists. There's 5 of us who rotated out to the federally qualified health center. Currently, that's changed now, where I have a physician assistant, I have a nurse director, and a patient navigator. But it used to be 1 oncologist and our nurse navigator. And the PCPs will refer to us for any cancer-related questions. So I always say, lumps or bumps, blood problems, other issues. Now I'm going to tell you what the conversation was when we started this program. They said, Chris, you're going to be flooded by benign hematology. That's the first thing they told me. You're not going to do anything but simple blood stuff. 2, they said the PCPs are going to hate you and they don't need this program. And 3, you'll never get any oncologists out there to do this work. Wrong, wrong, and wrong. So, but that's what they told me at the beginning, and I tend to be a little stubborn. So the PCPs seem to like us out there. We did have to buy time, and we did publish some work on how we implemented the program. This was not easy. We didn't walk in with a blueprint. I had some ideas, but I had to work with the community leaders to build the program in a way that made sense. So I'm skipping over it. Like, we just walked in, implemented the program. They said yay, and they moved forward. That's not how it went. There's a lot of skepticism. What does the Dana-Farber want with this program? What are you guys going to get out of it? What's it for you? What's in it for you? And you have to just kind of sit and ride with that. Say, well, I'm interested, and demonstrate with your actions, not just with your words. I'm going to keep coming back, and we're going to build this iterative program in a way that I hope that can demonstrate to you that we care about the patients, and we can work around the process clinically to do what works for you. And so this is really, the clinical services kind of a summary, right? We do some cancer screening, we do diagnostic workups, we do referrals for second opinions. So just to be clear, we are not giving chemo there. Right? We are not actually doing an official, I'm not working as a lung cancer oncologist when I was in that clinic, giving a second opinion. If the person needed a true second opinion for diagnosed cancer, we would either send them to our survivorship program or into our disease center at the cancer center. But some really interesting things started to happen, right? So this is a little bit, we have a publication that will be coming out. So it's fair to kind of show this. Things are under embargo, but this is stuff that we presented in abstract form in other places. So what we did is we put a cohort together. We had now there's 700 patients that have been in the program, but we went from 2012 to 2018, and we had 366 patients who had consented to be part of our cohort. We had 85% rate of people saying yes. So most people said yes very easily to being in our cohort. And the idea was we have this co-located cancer outreach program. What does co-located means? It's just a fancy word for saying that we were on their site in their center working under their license, right? So that's what that means, as opposed to being outside and referring in. And so the idea was to try to, want to expand the timeliness of these evaluations. And so the median time to resolution was really the metric we used. And we wanted that. That's basically from the time that we got them into our clinic with the referral to when a plan was made that would address the issue. So for cancer stuff, that could be the plan after they saw the surgeon. It could be the plan after they saw the medical oncologist. But generally, it's when the plan was made, then we know that that was resolved. And so what we found before we got there for cancer patients, the median time to resolution was 32 days. Our goal was to try to get it under 21, and we got it to 12, which surprised me. The thing that I did not expect, and what I had to really soft pedal in the publication, I've been trying to get this paper published for literally like 7 years. What we didn't expect was increased clinical trial enrollment. And you're thinking, why wouldn't anybody be happy about that, Chris? Wouldn't that be great? Why would you have had such a hard time? Because nobody believes it. Everybody's like, what's the mechanism for that? I don't know. I have some hypotheses. I think seeing us being consented on our cohorts, kind of involving with our navigation folks, talking about that meant that when they did have a cancer and they needed to be on a clinical trial, they were much more open to it. But this was, and if you look at what we did is we talked about the whole cohort, 82 patients who had a cancer diagnosis. Probably a subset of that actually had active cancer. The percentage of the folks who had active cancer who actually were on a clinical trial was 24%. So I kept trying to first I tried to bring it up, then I tried to hide it. And then each one of the reviewers would be like, first they'd be like, well, why don't you talk about this more? And then I would, and they'd be like, well, I don't know what the mechanism is for this. So we don't want to accept the paper. It's really been frustrating. So we're hopeful that, that the current reviewers seem to understand what we're trying to do. Just to give you an idea of the demographics here, and again, we don't have to spend a lot of time on it. It's mostly a Black population, and there's a Dominican group there. So there are people who identify as both Hispanic and Black. So if you look, right, 47%, if you're looking here, identify as Black, and then you add on to 26 who are 26% who said they are Black and also Hispanic, and then there's a separate group of folks who identify as Hispanic. So we had about 15% white folks there. The difference between the blue and the kind of orange is folks who had cancer or had a cancer diagnosis, and that's a full group. So and if you looked at the insurance, this is a patient population that was something like 75% had safety net insurance, Medicaid. So this is, not exactly what you would expect from a federally qualified health center. Who do we see? Well, we built some programs. We started just doing diagnostic work, but we actually built a lung cancer screening, smoking cessation counseling program there. We did some cancer genetics counseling and testing. And again, that came because we kept getting all these referrals for history of cancer. And then we were sending them into Judy Garber's cancer high risk clinic, and they were doing tests on them because they were legit. These were real folks because I'm a lung cancer doctor, right? So I would say, oh, this looks like according to NCCN, it should be right. And I'd send them into Judy and she'd say, no, this was real, Chris. We probably should have one of our medical geneticists do a clinic there. So we did that. And Humarana published a little bit on that as well. And that's something that we built in based on the demands of what we saw there. And then 22% evaluate for cancer. And then that heme that was going to overwhelm everything. Yeah, it was about 20%, but it didn't overwhelm everything. And the way I would say this is, right, if you look at the median time to resolution for the entire cohort, it was 25 days. So for people who didn't have cancer, and it makes sense, it took a little time for that to resolve, right? Yeah, weight loss, and then, or maybe you had a low white count and we're watching you and we're going forward. So that made sense. And we did this with its program evaluation rules. So we can, talk about this later on, but it really shocked us at how effective it was. It's a small intervention. One center. We're not trying to make too much of it. It's only my life's work, but I recognize it's just in one spot. Now we've expanded it to other places, and our goal would be to do some cost efficacy, looking at that, and then also trying to do some pre-post work before we go to our new place. So I guess I'm probably going to skip over this part because I want to make sure we get to some of the other aspects. And I promised Jamie I would try to stop in another 15 minutes so we can come back to this. But I think what I would like to say here is the folks who didn't have cancer, most of those folks are going on a surveillance plan. They go back to their PCPs. We try to keep people at the center before, not going to the cancer center. And the other part is if you had an insurance that excluded you from the cancer center, so it was only about 10% at that time, which has actually gotten less now because there's some different contracts. But about 10% of the people did have an insurance that excluded the cancer center as a high cost center. Usually they're managed Medicaid programs. General Medicaid we took, it's not a problem. It's certain managed Medicaid programs. We would still navigate them to whatever system that they were in. So the idea wasn't like, oh, we can't fix that. No, I told our navigators, well, you will call that system. You will find out what the appointment is. You will put in your chart and put in a chart what the appointment is and who that person is, and you will continue to follow up with that patient because we're still navigating them. And sometimes the patient would say, oh, but all my care's over there. Okay, that's fine. We're going to get you to where you need to go. It wasn't about bringing everybody just to the cancer center, although of course I could control the orders and getting people in quicker in a place where I knew the back numbers and getting folks in. That was very helpful, but it was really important to me and a promise I made to the community. This wasn't just about getting more people for Dana-Farber. Okay, it wasn't all great, right? Nothing is. It's really kind of hard. There's some good things. PCPs liked us. We reduced some of the patient wait time. We built new programs. That's great. What was hard? Well, you know, these federally qualified health centers all compete with each other. So it was very clear when we talked to the chief medical officer there, what we were going to do, that we were in this model and we were going to expand it. So after a couple of years, we went to expand it. They were really mad at us. I was like, why are you mad at us? This is a program that we want to use. They're like, you know, this is a program for us, for my health center, not to be shared. A little tension there. I have a belief that when you're in somebody else's house, you respect their rules. So when we wanted to write a bigger grant to look at specimens, biospecimens, and trust me, we would have been able to do that very easily. The people who ran the health center said, no, you can't even ask the patients. Now, I could have just pushed it because we had a whole research agreement, and according to the research agreement, I could just ask these patients, but obviously that would be disrespectful and it wouldn't help us. But it was not great for the history of the program at Academic Center. You want to be able to bring these bigger grants in and build off of this, and it would have been beneficial for the patients too. So, you know, these are some of the compromises you have to make. The relationships in the community were more important. And there's a lot of back battles I had to fight with my own institution about why we were there. At that point, I said, we're building a clinical program. I'm not putting the clinical program out because it is not helping on the research side. And sustaining this, we did a lot of philanthropic work. And it was only because every time I had an opportunity to have some leverage, that's when I got more things in the operations budget. So, you know, that's probably not how it should have been done, but that's how it worked. This Chief Clinical Access and Equity Officer. So I appreciate Jamie talking about the title because I purposely wrote it myself that way. I made the title and I did it on that way on purpose because I think that's the work that we were doing. We were working on clinical access and equity, and I felt that it should describe what we do. And that came up, to be really frank with everybody, post-Floyd, right? So pre-Floyd, we were doing this work for about 10 years in the community. Post-Floyd, people came to us and say, oh my gosh, this work you're doing is great. I said, really? It's the same work we've been doing for a long time. Thank you for recognizing it. But, and then the idea is that to have a voice to unite some of this work all the way across the Cancer Center and the Institute was really important. So 3 areas of focus. 1 is building the measurement agenda. 2 is really kind of advancing what we need to do with building new interventions through our infrastructure and operations, and then also locally and nationally look to drive innovative processes. And so this is just, again, the slide deck is available, but kind of focusing on the clinical access areas, the 2 places I want to touch on. This pilot that we're doing for navigation at the Cancer Center, not the navigation we're doing at our federally qualified health center. It's different. And just letting you know that we continue to work with our clinical trials access task force. And for the interest of time, if I run out of it, that might be the area I skip and just get to, you know, the end point on that. And we do a lot of research. The point of this lecture is not really talking about the research, but there's a lot of stuff that we're doing in collaboration with other folks. So, who's there? And again, the most important thing for our community work is Ludmila Svoboda. She speaks 5 different languages. She is the partner that helped me build this program. And we took a chance on each other in building this program. I asked an infusion room nurse to take a part-time job and a huge pay cut to come work on this crazy idea in the community on philanthropic money. And she said yes. And, you know, which was a chance that she took. And I took a chance on this Czechoslovakian woman. I'm going to put her in the middle of like the blackest part of Boston and have her engage with our patients and make sure that it works. And it did. So really, she and I have really worked together on the clinical aspects of the program. And now Laura is our PA, who's really done a lot of good work there. We have program manager and our research managers. And what you're seeing down here, we have a series of navigators. And we're going to talk about that in a minute. And we also have 2 faculty that are associated with us. Narjas Flores now, she used to be Duma, I have to update the slide, who is a thoracic oncologist and has done a lot of work in equity and thinking about trainees. And now she's going to be focusing on lung cancer cohorts and sexual health for that. But she is the associate director of the Cancer Care Equity Program. And Shale, who is actually, she has a lot of leadership at ASCO for sexual and gender minoritized populations. And so she is actually helping us as a liaison for the network work that we do. Okay, so what is this? So this is just trying to put this in a box because people say, well, you got this chief clinical access thing. What is that? Well, think of it this way. This is spanning everything. And the Cancer Care Equity Program is like the action arm for the work that we want to do for the Institute, right? So there's navigation, our outreach programs, our studies, the design that we do for our research mentorship program, the data dashboard, that's all under Cancer Care Equity. Then there's some other stuff that I work with other people in the Institute on, right? Clinical Access Committee and our COE and, kind of the ad hoc consulting for the Institute. I always say there's a disparities cleanup on aisle 3. We need to get Chris, and then they call me, and then I have to talk to them about things. And then some other stuff that we're doing that's, not just local, as we're looking at stuff both in Massachusetts and across the country. So what is this navigation issue? So navigation is a very broad topic. And we're talking about the Harold Freeman model, which is really, Harold Freeman is an incredible distinguished surgeon who'd been at Memorial Sloan Kettering in New York for many, many years. And he actually was talking about using navigation, focusing specifically on underserved and historically marginalized communities to kind of bring them into cancer care. And we like that model, right? Really focused on the people who need it the most. And the idea is this should be working anywhere along the continuum, from prevention all the way to end of life. We're specifically focused mostly on the detection diagnosis part because prevention is underdeveloped at Dana-Farber. Sorry, Dana-Farber, it's true. Many of the cancer centers have underdeveloped their prevention arm. They're catching up. And the goal of this navigator is these are people who are already in the Institute. And these are people who are going to be proactively calling the new patients, doing social determinants of health screening, and then connecting them to the other resources. They also accompany patients to visits if they so desire. So the idea is to really assess their needs up front and then make sure that they get connected. And if they want to, this is a person who can sit with them in the visit. Now, these folks are not nurses, so they're not expected to answer clinical questions. However, they are connected because we've integrated this into our disease process and are in the meetings with our nurse navigators and our clinicians, so they can really direct folks right to the nurse navigators who can answer the critical clinical questions. And it's really been quite something. Now we have a whole working group that we tweak it for each disease center. It's a little bit different in GYN than it is in thoracic. It's a little bit different in each one. And this was based off of philanthropic work. But the argument I made with the agreement I made with the institution is we will do this. We'll have 3 years of philanthropic funding, but the metrics we collect, if we show efficacy, they're supposed to put the navigators on the operations budget. Because again, this is a clinical program and it should not live on philanthropy alone. It can start there, but we have to really flex it. We'll see if they keep their promise. As I said to Jamie all the time, I'm not against embarrassing people and shaming folks. So if they made a promise to me, they're going to hear about that. But it's my goal to collect the data though and show people what we're doing. And this is just telling you where we are so far. GI, breast, and thoracic was started. We're about to do GYN, and then each one we have funding individually. We go through it. We have different working groups that work on data. I'm not going to spend too much time here, but just to give you some criteria, we started out saying you had to be an adult, new patient. Why adult? Well, because pediatrics has a very different approach. Actually, pediatric oncologists are much better about being involved in the diagnostic process than adult oncologists are. That's just the truth. And also the volume is very different. It's, so we're concentrating on the adult side. And then they had to be in one of our priority neighborhoods. So this is race agnostic. However, we're picking our priority neighborhoods that have, area measures that show us that these are folks that need this the most. So still disproportionately helping Black and brown communities. And then you could be referred if you come from one of our, federally qualified health centers, that's another handoff. That's another way to get in. And then we started out with just new patients because we wanted to make sure we didn't overwhelm the navigators. And then now we also have established patients. So if somebody is already getting treated, their provider can reach out to us if they meet the criteria. And this one we expanded a little bit. So if you have one no-show and you are Medicaid or uninsured, then that's another place we get into the navigator. Or if English is not your preferred language, and again, there's any evidence that you're having trouble, our navigators will reach out as well. And then some of the metrics, these are process metrics first. Our data group is working on the kind of research metrics, but the idea is what's the engagement? How many touches have we had? What's the resolution of the barriers? Did we reduce no-show rates? Did we have patient satisfaction scores that are good? Did we reduce the time to the first consult? Getting all the demographic information, and the institute, are they using our gateway? Are they using our gateway? Chris, please show me that they're using our gateway. Okay, we're gonna show you if they're using our gateway or not. And we have this data analytics and research work group, and we're gonna be actually looking at beyond process measures to outcome measures that we're gonna look at. So the white paper we're gonna be working on in a couple of months, and we're gonna do some qualitative research work to look at both the patient satisfaction and provider satisfaction with it. And we also have been lucky enough to get a business intelligence analyst to help us build our dashboards. And this is not the live dashboard, because the live dashboard you can click on, you can get individualized data, race data, ethnicity data, stage, which disease center you're in. It's really quite something, and something that I wanted to do about 10 years ago. We hadn't been able to do it. So I'm really, really pleased. But this is just an example of what the dashboard we have that we built. So I'm going to skip through clinical trials access because I want to make sure we get to talking about transdisciplinary research. Just know that we have a committee, and I'm just working on the community partnerships part. There are a lot of things you need to do to make this better. So part of it is what's the current state and what's wrong with the current state? And then how do we fix it? Your protocol stuff, a lot of stuff, it's not sexy at all. Look at your protocols. Are you getting them translated? Is there language in there that's excluding people? Are there criteria that are just boilerplate from your templates that you've carried over for 10 years? Rooting all that out, working with your office, talking with your clinical trials folks and your SRC to make sure you're not going to slow down the process, because they don't want to slow down your process at all. And then getting money to make sure that we can target stuff for patients. My group is focused on community engagement. So I really have this two-pronged approach. Everybody wants to give people education about specific clinical trials. The truth is, you got to get to them before that. Right? You got to actually talk to a community about clinical trials even before people are thinking about clinical trials. And so I have a pre-diagnosis process that we're working on. And that's what we'll show you a slide of. And then the post-diagnosis, which is you're in the office. How do we help the clinicians, especially in our satellites that have less resources, really connect with patients who are coming from historically marginalized backgrounds? And the idea here is just to design and implement a clinical trials education program in partnership with our community group in and around one of our satellites. So Lawrence, Massachusetts, a high Dominican patient population, and really have had some great relationships with them. So we're sitting down and putting together our clinical trials educator program. And here's our timeline, doing some interviews. It's not, again, none of this is reinventing the wheel. It's just actually trying to not only do it and publish on it, but have it in conjunction with our clinical operations. Okay. I'll take a minute to talk about transdisciplinary research. And I think this is something that is extremely important. I've really had a great opportunity to do this once. And the P50 we worked on with David Williams, who's a giant at the School of Public Health, and some other folks. And we think about cross-disciplinary research. Most of us are thinking about multidisciplinary research. So disciplines working together, but not really creating a new space. And then there's the idea of interdisciplinary research. But transdisciplinary research is really, you're really outside of your own sphere, and you're kind of forming your own space. And I think Mfumi in Chicago did this with breast when you had the work that she did over a decade ago, where they're linking the outcomes that they had to broken windows in the street, and the mouse models that they had that showed that if you had trauma in the mice, that they didn't do as well with their treatments. That was elegant. It was taking things from translational, basic science, mouse models, looking at clinical trials, genetics, and then linking it to area measures. That's beautiful. That's the kind of thing that you want to do. That's how you change the way we do things. And just to criticize our own stuff, I just told you how much I love cancer care equity programs. It's not transdisciplinary enough. Yeah, we got doctors and nurses, genetic counselors. We don't have any social behavioral scientists. We don't have any policy experts. We don't have any health economists. We don't have any bench researchers and translational researchers. We don't have the last two because we don't have any specimens. So that's why. And then this is a small cohort. So how do we get the health economists interested in that? And then, like I said, no biospecimens yet. We're working on that very gently. And as we expand to other community partners and our cohort gets bigger and bigger, I think we will be having more. But this is a good example of how, we didn't really have a true transdisciplinary team. And it's not easy to do this. And this is, again, work that Dr. Geller and Cannon has really published on. I think it talks about what are the challenges. Like, so you put this team together. First of all, you got to build it around some great grant, perhaps a spore. And then the problem is how you do this to bring these different people together who don't get your discipline, right? Conversations I've had over and over, and even today too, about some folks not understanding what your research is and why is that. MDs tend to be, well, I know about clinical trials, I know about translational research, and I hear about that stuff in the lab. I don't know anything about social behavioral stuff. I don't know what that is. How do we fix that? Because that really needs to be that's the way that we're going to put this together in the future. And the hard part is there's got to be this person, they talk about this as the boundary spanner, the person who's willing to connect all these different folks. And in our P50, I would say that was really David Williams and Matt Meyerson, who were really willing to put diverse team members, not just racially diverse, but we're talking about diverse thoughts, diverse backgrounds. But it's hard to find people who want to do that. And how do you allocate for that? And then when you're ready to publish, how I publish and where I need to publish it is very different from where other people do. So it's tricky. It's not impossible. It's definitely worth it. Okay, I'm coming to the end. So here's the opportunities, right? The clinical access and innovation projects. Look, these are just a couple of examples. Sam Seichert and Marjorie Charlotte did a great intervention on lung cancer screening in North Carolina. It actually really alleviated the mortality differences between Black and white folks and increased survival for all comers, Black and white, in that intervention. And it was published, I think it was in Journal of Oncology Practice, but why wasn't that paper a New England Journal paper? Why wasn't that paper in a higher profile journal? Because that intervention was great. And I'm going to be honest and tell some tales out of school. I might have written to the editor to tell them that if they could not publish that paper, given how great the approach and the metrics were, they need to just admit that they're not going to be publishing any work that is done, looking at interventions, because there was a little two-faced thing going on here. Oh, we're really open to this. But I will tell you that paper originally was not received very well. And the editors were asking questions, and I'm not on the paper, by the way, just be honest. The editors were asking questions that were really, I don't know if I believe it, all this other kind of stuff. And I just said, look, reject it or not. But if you're going to reject it, don't pretend that you want this work. And I'm not saying that that's why they took it. I don't have that kind of clout, but I was sick of them telling me that this is what they wanted when they really weren't going to publish it. So when we do these interventions, do these imaginative interventions, you want to measure your impact. There's so many great things that we've done that we didn't really measure the impact. We do it, we publish it even, and we come up with the idea and then we don't implement it, or we implement it and we didn't measure the impact. That's the key. And then thinking about community facing navigation. I think this is really important. You can do lots of things with navigation. There's an internal navigation that almost everybody has. That's great. What I'm talking about is community specific navigation that's focused on our most marginalized communities, and it's integrated into your health system. It's not standing outside. And as you know, and that's the way we kind of honestly address the clinical issues. And then you heard me talk about transdisciplinary research. That's the way you're going to do it. And that's what the NCI Cancer Centers are supposed to be doing. So I feel that's really important. And then this to me is obvious for folks who are involved in this. Community engagement is not easy. It's hard. It's a durable thing. You got to keep coming out there. Sometimes you come out there, people they doubt your intentions. You got to keep showing up and prove it to them, and give back to them. And I quote Electra somewhere down here, where she said to me, you got to leave the community better than you found it. And I just thought I never shook that. This is one of our great epidemiologists. And she said, when I'm doing the work that I do, I got it any way if I can leave the community better than I found it. And I try to think about that with the work that we do. So, right, you want to build these clinical access pathways, think about lots of different ways to go through this. And faith-based groups are good, but think about beyond that. What about your large employers? unionized areas, people who work in your kitchens. Like, think about these. There are other areas to get to populations that it doesn't have to just be going to the church. The church is good, but you can get beyond that. Your community leaders, your politicians, engage all of those people, right? Because there's different things you can get from that. And then you want to, listen to your catchment area communities. It has to be bi-directional. So many times we come in with an agenda, and I've done this. And we come in with my plan, let's go. And the community's like, no, we're not doing that. And you have to adjust. That's what this is all about. It's not just us telling the community, it's listening as well. And then, NCI always tells us, they want us to build on our strengths in basic sciences and focus on the opportunities, right? This is just this NCI session, and I just want to focus on the end where this was pre-pandemic, and they said, NCI, they want measurable impact now. And the community outreach has to go beyond education and deal with the barriers. They're not going to fund it that much, but that's what we have to do. And then the academic medical centers, you really have to figure out how to promote and respect the work of the faculty that is doing this space. People are still working on that too. It's hard to get promoted doing this work, and we really need to change that. And so this is my almost last slide. I think, talking about accountability. So a picture up top is my mother. As I mentioned, she passed a couple of years ago. And my mother used to always say when she was mad, and my brother and sister are down here. That's a much thinner Chris Lathan. I don't know where he went, but she used to say to us when she was angry with us, she'd say, I'm tired of talking. It's a very common thing in the South in a place. I'm tired of talking to y'all. And that's how I feel. No, I'm not tired of talking to you. I'm tired of talking about this. I really want us to move to action, because the truth is there's a lot of people talking about what we should do. But the truth is, what are they doing? Now, the people are doing it. You can see it in their actions and in their deeds. And I think this is one of those things that we have to really judge folks by what they're really doing and continue to do. So 2020, people said, oh, this is year of racial awakening. And now we can say structural racism. I couldn't say that before that. I really could. I know you think I'm exaggerating, but I couldn't. But those are words. Action is needed, and we need to hold our institutions accountable. And we have the opportunity to turn these words into deeds. And I think all the focus and effort that we do on our basic research and translational science, we need to bring to this work as well. So with that, thank you for your time and your attention. Oh, I have to do that.
Thank you very much, Dr. Lathan. I'll only say I told you. Just a wonderful outlay of some of the theoretical foundation, the thought being put into it, as well as some very practical and engagement opportunities going into the community. We did get a couple of questions from the chat that I wanted to pose to you. First, starting off with Dr. Russ Vasco. Asked a question about, well, first I was really impressed with the co-location effort, but wanted to ask about some of the outcomes and whether you're considering cost effectiveness and how that relates to the potential sustainability and some of the metrics that you use. I also integrated, I'll throw in the fact that I thought it was incredible that you were thinking about sustainability in the sense of holding your system accountable. You're going to go out and do this work with funds that you've generated through your own philanthropic efforts, but also getting buy-in from the institution. If we hit these metrics, that this will become part of the operational budget. And so you could just spend a couple minutes chatting about any of those thoughts.
Sure. So I would say that taking the second part first, I learned that. So when we first did our outreach into the federally qualified health centers, I hadn't been that seasoned and I was just doing it. I learned from the work that we were doing there that it wasn't easy to get it on the operations budget unless I had leverage. So when we started doing our navigation work, I brought it up front. So those were lessons learned. Regarding the outcomes, so I did kind of move quickly through it. The idea is to take what we've done. We do have more in the paper. I wanted to get the paper published, to be really honest. There's two reasons for that. One, some credibility that helps us there, and we can expand the model a little easier. And then the idea would be to get to some cost effectiveness. Now, if you look at some of the navigation studies that have been done, generally navigation is almost always cost effective. If anything, it tends to, the worst, it breaks even. But private practice oncologists are putting in people to navigate their cancer service line to increase revenue, because you can direct people. So, but we do want to get to that, and that will be the next part. We've expanded from, so we're in our original we're in the original federally qualified health center. We expanded to 2 more. The original one that we were in, they said we think we can do this by ourselves now. Okay. So we said, okay, we kind of moved, and we're still following some of those patients for lung cancer screening, and we're in 2 new sites. When we expand to the new site, the idea is to do some pre-posts, and hopefully then we can bring in some of that other analyses. But we do have other outcomes that we're looking at as well, besides time to resolution. It was a small cohort at first, so I had to be careful about the power. Yeah. Yeah. No. Gotcha. So going back to the clinical trials part. So the skepticism was really because we don't really have a good mechanism for this. Why would it be that they came to see us, and then when they went to the cancer center, they'd be more likely to be on clinical trials? I do think, as I mentioned, it's more about, so I have a person who comes in after there's a warm handoff and says, hey, we have a cohort, you don't have to be in it, the usual way that you would engage and your CRCs might engage. And I think that kind of sets the table for them. So when they end up at the cancer center and a CRC comes in and says, hey, we want to talk about this genetic study, it's easier for them. I will tell you that it is mostly registration trials as opposed to therapeutic trials, which makes sense. And on the lung cancer screening part, where we started, we got a little grant from CVS back in 2013. And so it wasn't covered yet. So we started doing it then. Most of the lung cancer screening folks are not, they're in our cohort as far as being able to follow their outcomes, but there's nothing specific about lung cancer that we're doing in a study for them. It's just general. So we could see, we do have, actually there are 2 people who are doing other studies based off our cohort to go in and talk to our lung cancer screening folks. And so we're hopeful that they'll be able to get some publications out of that too.
One comment. We're going to take a couple more questions, but I just want you to take note. Please go do the quick survey online for our seminar evaluation process. We greatly appreciate it if you would do that. Also, the mics aren't working.
Okay.
For online, so if you could repeat the question.
Okay, I'll repeat the question. Got it.
They hear you.
Okay.
They just online wasn't able to hear.
Got it. Yeah. Okay. Right. So I wish it's almost like I planted you there for that question, because that's, so the question was really looking at, as we look at this higher percentage of people who are in clinical trials, and mentioning, since it's a complex issue, maybe some of the criticism here is trying to find a simple, direct correlation in the methodological rigor that we use isn't applicable in this scenario, and that we need to understand that these are complex interactions and look at the outcomes and then go back and try to drill down and figure out what it could be. And perhaps these are the tools that we would use going forward. I agree with that. I think these plus everything else. I'm never an evangelist in just one approach. I do think in oncology in particular, we need more specific interventions that have local impact and direct impact into the community, along with the other research that we're doing. It's not either or. And I do think that this is a way to do this. And I have nothing wrong with rigor. That's good. Challenge me a little bit, push us, make sure we're using the right approaches. But what I'm finding is they're using that. I can get a clinical trial that had 15 people on it published, right? If the outcomes are great. How can you tell me that looking at 300 people, that's not enough? And I don't know the direct correlation. I don't know why your drug is working either. You don't know why your drug is working, right? So don't sit here and tell me it's a double standard is my problem. And I think we need to be able to acknowledge that. So I was getting a little hot about that. I apologize, but that's how I feel about it. Right. So the question for folks online was that, transdisciplinary research is hard. And one of the reasons that's really hard is which journals do you publish in? How do you publish in the journals? And that's a big challenge. So there's not a magic bullet here. I can tell you the things that I've done to work around that. Even though people talk about team science, unlike, if you're a physicist, right, they do real team science papers. Everybody's on the paper and it's okay. And we don't do that as much, right? And I think what we've done is then take a look at the work you're doing and try to divide it up. Okay, so look, I know that this social behavioral scientist publishes in these journals, and that's really important, and they could be the lead for this one. I know that I have a translational scientist who's, everybody's on the paper, but you move the emphasis of the journals depending on the people you have. It's not perfect because not everybody's gonna have, like for me as a MD, publishing my work in like the Journal of Healthcare, for example, which is really focused on interventions is good, but none of the clinicians are gonna read it. None of the oncologists are ever gonna read it. I'll get it published, but they're never gonna read it. So there is some give and take there. But I think also you ask the more senior people who are doing this work, maybe not to gobble up all the space either at the top or the end, and be able to have some space to really reward the people who are doing the work so you can publish in the journals that are relevant to them. And if you do it right, you can have a series of publications that are coming out that are in many different journals on different levels. But that's an imperfect thing. And you have to think about it beforehand, even before you do the project. Online there, he's saying that approach can short sell the transdisciplinary nature of the work. Yes, but think of it this way. The work is getting done. So the publications is a game. I'm sorry, right? So the game and the coin of the realm is still grants and papers. So you still have to win the game. And I don't want the researchers who are doing this work to lose the game and do good work. I want to do good work and get it published. And so to me, it's a mitigating strategy until something else changes. But at least you still get your publications in the journals that are right for the right folks. But you're right, it's imperfect.
I'll add that I've accomplished this in my career by just publishing in those.
Same.
Thank you, everyone, for joining today, both online and in person. And thank you, Dr. Lathan, for sharing your insights with us. Glad you're here.
Thank you very much for inviting me. Thank you very much.